Regarding uncemented stem, it saves intraoperative time, high cost, difficult to control version. Neck cut is critical as a guide. Calcar fracture can happen, need rigid fit to reduce micromotion to less than 50 micrometer to prevent formation of fibrous tissue at the implant bone interface. Two methods, press fit or line to line. Press fit, slightly larger implant than what is reamed and broached, relies on hoop stresses for initial stability 4 to 6 weeks. Then on bone in or on growth, for example, corail implant. Line to line, size of the implant is same as reamed. Screw often placed in acetabulum if reamed line to line. It happens due to osteointegration, attachment of lamellar bone to the implant without intervening fibrous tissue. Must have viable bone, avoid placement in irradiated bone, implant manufactured from titanium alloy. Porous coated, bone in growth, titanium plasma spray is done. Thickening of the coating 50 to 100 micrometer. Pore size ideally 50 to 150 micrometer. Porosity percentage 40 to 50% porosity. Too little, weak fixation, too much, shear of the metal. Extent of port coating, extensive coating like furlong and corail, better initial fixation or proximally coated. Regarding uncemented stem loosening, it is a well-fixed bone with no reducent lines, proximal stress shielding, stable with fibrous ingrowth, uniform radiolucency less than 1 millimeter in line with no surrounding sclerosis or subsidence, unstable, loose, irregular, wide radiolucent lines, micromotion at the bone prosthesis interface if less than 50 micrometer, bony bony union. 50 to 150 mix and more than 150 micrometer fibrous union. Spot welding, a small area of sclerosis originating from endosteal surface and abutting femoral canal, strong indicator of stability. Bone pedestal, transverse sclerotic line below the tip of the cementless stem, sometimes but not always associated with loosening. Uncemented commonly used, corail implant is mostly used. And I said corail is extensive coated. The bonding to the bone is by bone in growth or bone on growth. Bone on growth is because there are divots and not pores. These are implants with great blasting of aluminum oxide to create surface roughness of 4 to 7 micrometer or plasma spraying of molten metal. Extensively coated fixation strength is less than porous coated. Plasma spray can be done by calcium hydroxyapatite. It's oxyconducted and shorten the time of biological fixation. Then it's bone ingrowth, extensively porous stem with fiber mesh. Regarding stem geometry, they can be flat, tapered, achieve early fixation by wedging of a rectangle into the circle. Mismatch of geometry achieves good torsional stability. Fixation occur by metal medial-lateral engagement. Dual taper achieve fixation by completely filling the metaphyseal canal as circumferentially engages the femoral cortex proximally. So when types of taper discuss, you can draw a AP taper which is a single taper with anterior posterior. Then you can talk about the double taper, which is present in anterior posterior and lateral views. And then you talk about the triple taper when we have AP and lateral, and the transverse also is tapered.